All right. So this is going to be a recorded lecture on respiratory care and or how to deliver respiratory care in like a long-term um, situation. So this is a kind of a good review of some of the CMS type requirements to send uh, patients home on respiratory therapy modalities like oxygen or CPAP. And then just it will also cover some of the like equipment variations that you're going to see outside the hospital than what we're typically used to seeing inside the hospital, um, and cover some important aspects of patient education, caregiver education before we send our patients home. So, the information covered in this chapter is going to be chapter 57 in your Egan's book. Just a few objectives. All right. So, Patient Protection and Affordable Care Act, or sometimes you guys hear this referred to as Obamacare, has really helped um, expand healthcare to uninsured Americans. Okay, so there's a lot of political stuff out there about the Affordable Care Act or Obamacare, lots of bipartisan or party division over this Affordable Care Act that was passed in 2010. But it really, the goal behind it, if you look at the root goals behind this legislation, is to try to get more Americans covered under insurance, because bad payer mixes or people, uninsured individuals that end up in the hospital are not good for anything. That's why our insurance premiums are so high, those of us with the commercial insurance, because hospitals have to treat these people. And if these people can't pay, then the hospital has to absorb the costs somehow. Um, and usually it gets all pushed out to other patients with insurance. So American healthcare has a couple huge flaws. We won't get into that in this lecture, but um, the goal of the Affordable Care Act was to try to get more people off of like governmental insurances like Medicaid or Medicare, get them into these onto the exchanges to get some type of supplemented insurance, if their employers didn't offer it, and try to lower the instances of uninsured individuals coming into the hospital. The other thing that it did was to try to encourage preventative care. Or yeah, so encourage preventative care, whereas used to be that um, patients that were on Medicare or Medicaid were kind of almost incentivized to just not go see the primary care doctor and just show up at the hospital, and get treated in the emergency room. So there's been a lot of changes that have happened since 2010. There's a lot of work still to do, but mostly this has been trying to benefit us and benefit our patient populations to get health insurance, even if they have pre-existing conditions, get some of their preventative treatments covered or diagnostic testing covered. So we're not just treating or reacting to emergencies, but trying to prevent chronic illness or acute symptoms. Um, and then also, this goes back into the lessons we had about quality way back in survey of, having pay per performance. So hospital systems were part of this whole situation is that hospital systems were going to be reimbursed at a rate determined by how well they met certain quality outcomes, how well they met certain patient satisfaction outcomes. So, um, but one of the problems with this, and it's not just um, unique to this bill, but just kind of unique to health insurance coverage in general, is that we do have limited reimbursement for respiratory equipment outside and respiratory education outside of the hospital. If you attended conference this week, you heard a lot about different ways state and national organizations that's support respiratory therapists are trying to work to lobby government and legislation to try to improve this, because it is very important that these patients that are on respiratory equipment are being seen by a respiratory therapist and that this equipment is covered for them. Okay. So this kind of just covers what I just said, that reimbursement for care provided by RTs in home care is not currently being reimbursed by Medicare. And there's a lot of information out there, and there's more research being done to indicate that by involving respiratory therapy in these spheres, you're going to have better outcomes and you're going to reduce costs from readmissions and things like that, or increased length of stays or readmissions into the hospital. Okay, so some common respiratory care services that are going to be provided in that post-acute care facilities. So these would be like long-term care facilities, or even at home would be continuous oxygen. That's probably the main one. Long-term mechanical ventilation is another one. Trying to get patients into facilities that will take mechanical ventilators is challenging. Trying to ensure that the patient's safe and family members and caregivers in the home are properly educated is also a huge challenge. So there's really hospitals and social workers and things like that are working to get patients discharged, or between a rock and a hard place with a lot of our respiratory patients that require mechanical ventilation. There's not a lot of options out there for these types of patients. We also have aerosolized drug therapy, so doing respiratory medications at home, doing airway care, trach care, helping patients with their sleep devices, and monitoring to their effectiveness is another kind of key component in here. And then outpatient pulmonary rehab. So outpatient pulmonary rehab is another kind of thing that we're advocating. I would say that this is probably our second biggest professional issue right now, and that's under review in legislature, is how much we're getting reimbursed or looking at the reimbursement for pulmonary rehab. There's not a lot of reimbursement currently for pulmonary rehab patients. There's a lot of really, really amazing people out there that are working hard to try to document the importance of pulmonary rehab for not only our COPDers, but our interstitial lung disease patients, cystic fibrosis patients, all benefit from pulmonary rehab. But unfortunately, most patients don't get to utilize it due to poor reimbursement and out-of-pocket costs. So you might have heard the term LTACs before. These are your long-term subacute care hospitals. So these are essentially, these patients are admitted into these facilities, and sometimes they can kind of look like a hospital, but it's for that long-term care. So the patient's not coming there directly after emergency. They go to the hospital. This is kind of a segue. They get discharged to an LTAC to get kind of some specialized care. These are usually for patients that are very complex. They can't just go home with home care nursing. A lot of our types of patients end up in these facilities because they're vet dependent, difficult to wean off the ventilator. So these places do employ a lot of really experienced clinical staff, including respiratory therapists. They're very, very interdisciplinary, or they try to be, to try to help get these patients weaned off the ventilators, and then to a level where they can safely go home. Subacute, this is kind of the term for, giving patients that almost that level of inpatient care, but they're kind of stabilized. They don't need that hospital space anymore. So they usually have had some sort of injury or illness. They have kind of a plan of care already set for themselves with discharge from the hospital. Um, and they, will go to these subacute areas for like kind of more prolonged treatment. Obviously, the goal for the hospital is going to be the most expensive stay for patients. So the sooner we can get them discharged to like an LTAC or a subacute facility, that reduces the costs overall to the system and to the patient. And then these patients really do get specialized care at these types of facilities. That's the goal, is that they can still be seen by physical therapists, occupational therapists, speech therapists, respiratory therapists. They have nurses that take care of them. So they're still getting a very high level of care, but it's just with the understanding that it's going to be, they're on that long road to recovery. And then finally, home care. This is the kind of the most post-acute respiratory care. So this is, um, after they successfully, get discharged from an LTAC or subacute facility, or sometimes directly from the hospital if they meet certain requirements, they'll go into that home setting. So typically we are going to see patients with COPD in the home setting. The most common patients that we see in home care is COPD, cystic fibrosis patients, patients with neuromuscular disorders that are affecting their breathing, patients with chronic restrictive disorders that are affecting your breathing, or even lung cancer patients would qualify for home care. And that could look like oxygen therapy, aerosolized medications, other things to help them stay out of the hospital is kind of the goal of all of these things. Okay, so when you're looking at like the standards for delivering care in these areas, you're going to be following first and foremost those clinical practice guidelines set by the AARC. Um, these are evidence-based guidelines that are put together by super smart respiratory therapists on the national level to kind of set that standard for how we are going to perform the procedures. Then there's a couple of regulatory bodies that also kind of hold us accountable in the home care setting. So the largest purchaser of health services in the country is the government. So they kind of set the standard for what everybody else follows. So CMS is the Centers for Medicare and Medicaid Services. So they're going to kind of set those regulations. They oversee health coverage for elderly patients, disabled patients, disadvantaged youth. So anybody that's on Medicare, which is like I guess the best way I could frame that up is like the retirement healthcare is Medicare. You can also qualify for Medicare if you're deemed disabled by the state. And then Medicaid is usually for those disadvantaged, like low income, poverty level individuals, or children of adults who don't make enough money to afford health insurance or qualify to be on the exchanges. So So CMS really is there to make sure that everybody that's taking care of patients, whether it's the hospitals, these LTACs, the home care agencies, meet certain health and safety requirements. So those requirements are like called conditions of coverage or conditions of participation. So they will send out individuals to survey hospitals. If they get a complaint from a patient, you will have CMS show up at your doorstep, hospital doorstep at 8 o'clock on Monday morning. And usually every single hospital administrator is all anxious and nervous about that, because if you are in violation of CMS, you will not be reimbursed for any of the patients that you see that are on Medicare or Medicaid, and some commercial providers may follow suit. Okay. So private sector accreditation, these are actually the Joint Commission is considered a private sector accreditation. This is a voluntary process that all hospitals or most hospitals or healthcare facilities go through, because it looks good to be accredited by Joint Commission. It's kind of stating that, we practice at good quality standards. We deliver a quality product to our patients. Joint Commission is the main one. They send out surveys every 3 years, meaning that they show up at your hospital doorstep every 3 years, and review your practices and make sure that you're following your own protocols, your own guidelines that you set in place, that you have good quality measures in place for your patients. They also like review your employee files and credentials. So at that time, as a new RT, your employee file might be pulled, your charting might be pulled and looked at and reviewed to make sure that you met all your competencies to be in the role that you're in, completed your orientation paperwork properly, are licensed by the state and credentialed by the MBRC. So they look at all those types of things. The other one that your book doesn't mention, but just because I'm a product of Aurora, I know that DNV is the other main third-party accreditor that is used in our state. So the Joint Commission used to be kind of the only game in town. Aurora, I think, is the first to do it. Maybe other organizations will follow suit, but DNV is another similar to Joint Commission that accredits hospitals, but they do it on every year, an annual cycle. So, okay. Oh, I am not doing a very good job of clicking through these slides, but I just kind of covered that information for you. So private sector Joint Commission. Okay. All right. So traditional acute care versus alternate care setting. Usually the differences between being a respiratory therapist in the hospital and being a respiratory therapist outside of the hospital is that therapists outside the hospital usually have less equipment, less resources. I already mentioned there's not a lot of money that goes to home care, unfortunately, at this point. They have to work a little bit more independently. And this is true of some of you guys that end up at community hospitals as well. I'm not picking on Froedtert. Like, Froedtert's amazing, but you go work at an RT at Maine Froedtert in Waukee, you have 80 coworkers and you have tons of resources and tons of phone a friends that are right down the hallway from you. So you honestly don't have to be as independent, and I won't say you don't have to be as good of a critical thinker to work at Froedtert, but you don't have to work you're not alone. That's the best way to say it. You're not alone. You always have a resource there that can help you out. As you move away from some of these larger facilities where you're working more isolated at a community hospital where you're only RT on the shift, or if you work out at a subacute facility, you're probably going to be the only RT on your shift, or in home care, you're going to be the only RT in your region. You don't really have a lot of resources on hand to bounce ideas off of, ask questions of. So a lot of times, I think sometimes home care RTs, they get a little like us acute hospital RTs. We kind of look down our noses at them sometimes, but some of these individuals are, they're not just filling oxygen tanks. Like, some of these individuals have a very high level understanding of CMS and regulatory practices, and are really, 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 really smart at troubleshooting issues. And they're also very good at disease management, because they have to be. They're kind of, there's not a doctor there to ask. They're the resource for the patient a lot of times. So these individuals have to be extremely independent. They complete a lot more paperwork. Like I said, they're very well versed in the regulations, and that usually means a lot of paperwork. They often have to work on call. if case patient needs something over the weekend. And they are really part of a bigger, broader team. Like you work for a really good DME. And again, my experiences, my most of my recent experiences with Aurora at Home, which is the Aurora owned DME, and they have a phenomenal team that kind of works very well cohesively together to meet these patients' needs. And I'm sure like other organizations like Freighter, and I know Children's does a lot with their home care team as well. Okay. So when you get into like the multidisciplinary or discharge planning, this needs to be a multidisciplinary approach. Um, if your facility doesn't already do this, this is something that you guys should be advocating for at your facilities, is discharge planning team meetings that our RT is invited to. So my most recent facility, which is Aurora and Sheboygan, we went to discharge rounds every single day at 10 a.m. And at that round, it was respiratory, it was OT, it was PT, it was dietary, it was nursing, it was the social workers, case managers, and I think I said respiratory already, but respiratory as well. And we all sat down together and we went through every single patient on that floor and discussed what, when we were expecting them to be discharged and any possible needs that they would have. And those meetings were super informational because I was able to identify patients that maybe we weren't seeing for treatments, but may have a concern with oxygen going home or something else that they might need in the home setting that we would be asked to provide for them. Um, so, and that's really trying to help set the patient up so that they don't get readmitted. Hospitals get penalized pretty severely if your patient gets discharged and then gets readmitted into the hospital within 30 days for the same reason. We get penalized pretty severely by Medicare and CMS for that. So part of that discharge planning, we want to look at the environment that the patient's going to be discharging into. So, obviously our goal is to try to get as many patients home as possible. But sometimes, depending on the patient's needs, that's not really appropriate for them, or depending on their situation. I've had a lot of patients over the years that really, really, really want to go home, but they don't have the support that they would need to make that safe for them. So, obviously we take patients' wishes into account, but we also want to make sure that our patients are safe and that they're going to go home to a situation that's going to enable them to stay home without having to be readmitted. So that means that if we are discharging somebody home, we want to make sure that the caregivers that they have in place, family members, friends, whatever, are going to receive the proper training and understand the situation well enough to know that if they're really capable of taking this person home. So that can be, look like a lot of different things depending on the type of patient that we're talking about. But if a patient's going home with a trach and they have never been home with a trach yet, you need to make sure that every single family member or any caregiver, anybody living in that house, understands what it looks like if the trach becomes dislodged or obstructed, so that they can identify these airway emergencies and then what the proper steps are next. So, teaching them how to suction properly, teaching them how to replace a trach, teaching them how to provide manual ventilation in the home, all of those things. We need to make sure that we've done with the caregivers before the patient leaves the hospital. It is very difficult after the patient leaves our doors to do any of these things. So don't assume that the home care company is going to take care of this, because these DMEs, these durable medical equipment suppliers, are operating, as we just mentioned, under severely limited resources. I think that they would like to do more than what they're capable of doing, but they're just not getting paid enough to make it sustainable for them to be in the home as much as they would like. So if you guys working in the hospital can do a lot of that education, a lot of that reinforcement on the front end, that just makes everything easier with the process moving forward. Okay, so oxygen therapy in these alternate settings, this, like I said, this is probably our key thing that is going to be prescribed to our patients at home. So in order to prescribe oxygen, you need to have the prescription must include the flow rate at liters per minute and or the concentration, how often the patient needs to be using it, like around the clock with exercise or ambulation, while resting, whatever it is, how long the patient's expected to need the oxygen. So you send a patient home with oxygen, that doesn't mean they have it for life. Some patients get sent home with oxygen, they go through rehab, and then they can get weaned back off of it through follow-up appointments with their doctors and their DMEs. But there's only certain diagnoses as well that qualify for oxygen at home. Like you cannot send a patient home with their primary diagnosis of pneumonia. I've had to go yell at doctors a lot of times to be like, you have to change the diagnosis on this because the DME isn't going to cover it, or CMS isn't going to cover it if if it doesn't meet certain criteria. So it's usually a chronic condition is all that we can send them home for. Laboratory evidence, so this includes blood gases or oximetry. So your HOMO2 eval is going to get put attached to that order to demonstrate that medical necessity. So the physician usually authorizes that oxygen with a CMS certification of medical necessity form for O2. And they have to kind of follow up with their physicians once a year to demonstrate that they still maintain that need. Okay. So just a little bit more about qualifications for oxygen therapy at home. Typically, when you're doing that HOMO2 eval, you're going to have the patient resting on room air and awake, and you're looking to ensure that their SpO2 is 89% or above. So if it's less than 88% or below, they then would qualify for home oxygen. Okay. Then you would ambulate the patient and titrate the oxygen dependent on how much oxygen they need while they're up and moving. So a patient could go home with an oxygen order to say, 2 liters at rest, 2 liters per minute at rest, and 4 liters per minute with ambulation. Both of those things need to be documented in your notes. Okay, so supply methods, obviously they're not going to have a basement full of O2 tanks at their house. So oxygen is going to be usually supplied with like one of these 3 resources. So compressed O2 cylinders, these are those small E cylinders usually are kept at the house as backup. So it's usually backup to the liquid or concentrator systems. Or if the patient's leaving the house, they'll use this compressed O2 cylinders. So usually typically E cylinders. So if you are sending a patient home with an E cylinder, you should thoroughly review safety measures for the patient and any family members. And then you want to make sure that you've documented that you provided that education and that the family members are capable of doing this. I also usually make sure that the patient understands how to use the flow meter and the regulator on the tank. So you want to make sure that they're comfortable taking the regulators on and off the tanks, adjusting the flow on the flow meter. Usually the home care company is going to talk to them about how to fill the tanks, refill the tanks from their liquid oxygen system, things like that. Okay. If the patient needs humidification with compressed O2 cylinders, they're going to use bubble humidifiers at home. That would be what you would recommend. Okay, so liquid oxygen systems. So these usually are higher cost than the other delivery systems. So there's not a lot of places that will use them. But the advantages of them is that they can store large amounts of gas. Okay, so they can store large amounts of gas in small spaces, so that's an advantage of them. But like I said, they're more cost prohibitive than other methods. Okay. I don't think I need to know anything more about that. So typically, the liquid oxygen is going to be used for your patients that require higher liter flows. So, patients that need like more than 4 liters per minute resting. So typically those are going to be your ILD patients, your interstitial lung or pulmonary fibrosis patients. Those patients usually end up needing a lot of oxygen, and those would be the ones we would qualify for liquid O2 systems. Oxygen concentrators are probably the most common method that's used there. So it is a piece of equipment that is put into the patient's house, plugged into the wall, and is going to concentrate the oxygen in the room air. So it's going to be limited though to typically about 5 liters per minute. So you can't really go up over that, but some new recent designs have made that a little bit higher, maybe up to 10. These are kind of the most common way that we do this with patients. They put a concentrator in the patient's house and it's kind of a central location, and the patient has like 80 feet of O2 tubing that allows them to move around their house freely. They also do have portable oxygen concentrators, or POCs. These are kind of demand flowed conserving devices. So I usually call them O2 conservers. And it's like a portable pack that a lot of patients can wear that turn on only when it senses that the patient is trying to breathe in. So we'll talk more about that on the next slide. Okay. All right. So delivery method. The most common delivery method is going to be the nasal cannula. Transtracheal oxygen is used in select patients. This is helpful because it doesn't require us to use as much O2, because it's actually the transtracheal O2 catheter is going actually directly into the trachea. Through a small orifice in the neck, the skin in the neck, so the patient doesn't look like they're wearing oxygen at all because it's kind of covered up by their scarf. And then because you're removing that dead space from the upper airway, you don't need as much oxygen. But these patients, you always want to make sure that they're cleaning that catheter properly, and they can recognize when it gets obstructed. All right, so those demand flow systems again. These are those pulse dose O2 conserving devices that use like a flow sensor or valve that's going to only deliver gas when it senses that inspiration. So this is going to be a big cost savings, because the oxygen's not going to be flowing continuously. It's only when you're breathing in, not when you're breathing out. But you want to make sure that the patient is able to trigger that conserving device. So you should be testing the patient on this portable technology to make sure that it will actually work for them. So usually these the newer ones that are out are great. They've got like long battery life too. They're pretty small. They look like a little lunchbox. So it's been a nice nice thing for most patients would prefer that rather than hauling a big tank around. Okay. So when you're selecting which type of device you want to use for your patients, you kind of want to think of the three P's is what Egan's talks about. So the purpose, patient, and performance. Um, that goal should always be to matching the purpose or the performance of the equipment both to the kind of objective of the therapy and those patient special needs. So patients that need only a low flow HOMO2, um, and are up and about and moving around and going places, they might be the patient that I would want to do that portable concentrator for. If the patient's more homebound on low flow, I might choose a O2, more stationary O2 concentrator. If the patient needs high flows of oxygen, I might choose liquid oxygen in the home and then e-cylinders for ambulation. All right. Okay. So kind of a next kind of big area of respiratory therapy outside the hospital is that ventilatory support. So this is both invasive or non-invasive vent support. So non-invasive vent support has become a lot more popular over the years. CMS has determined criteria for reimbursement for patients that outside of just sleep apnea, need that non-invasive support for chronic hypoventilation or even COPD. So, anytime that we're using vent support in these alternate settings, we really want to make sure that we're doing a lot of kind of planning to make sure that the patient's needs are kind of being met, making sure that we're choosing the correct patients, making sure that we are providing good education to the families, and choosing the right types of devices for our patients. So with patient selection, most patients needing vent support are going to fall into like one of three kind of main categories, and that's patients that are unable to maintain that adequate ventilation. So these patients might just need non-invasive support nocturnally, or when they're feeling like they're struggling with their COPD or symptoms. Patients the second kind of group of patients would be patients that require continuous mechanical vent support for long-term survival. So this might be a patient who was a maybe a trauma patient who had a cervical spine fracture and needs to be trached and vented long term. And then sometimes patients who are terminally ill or with short life expectancies, they might, have ventilators at home. So, or in that short term area. And always remember too, with this one, remember, you want to always kind of focus on the goals of care with that last kind of patient population. We shouldn't be providing mechanical assistance to somebody that that wouldn't, in a situation that it wouldn't be improving their quality of life. So, obviously we talked about this in ethics. We talked about this in mechanical ventilation before. Vent support in those like end of life situations. Again, we should be focusing on comfort. So if it's something that can be used to make the patient more comfortable, absolutely, we should be proceeding. But we need to balance that against like, okay, we're not using this device to try to prolong your life, prolong your situation. It's just to improve the quality of your, remaining time. So, okay. So some of the things that, for vent support in the home to be successful, one is the willingness of the family members to to participate. This is going to go into caregiver education. So we want to make sure that we're properly preparing patients or family members and any other caregivers for that discharge, that home discharge. We want to make sure that we're going to have a comprehensive and established education program that these caregivers, family members would complete. And I would want to make sure that that's like a documented standard in my organization. And then, certain skills should be taught in it. Your book kind of goes through a bunch of them. So that willingness and that adequacy of family support is going to be key because they're going to be educated. They're going to be acting as both nurse, respiratory therapist, everything for these patients when they leave the hospital. Stability of the patient also kind of comes to play. Adequacy of that home setting, financial stability, insurance coverage, because as you can imagine, this is going to could potentially be a fairly expensive for the patient to be cared for at home. Okay, so picking between invasive and non-invasive vent support. So used to be that we would only be doing like that invasive positive pressure vent support for patients in the home setting. But they more recently, non-invasive support has become a lot more popular. In order to use non-invasive support, you really want to make sure that that patient's mentally competent and cooperative. That's probably the key one, because non-invasive is not going to work if your patient won't wear it. So if the patient's not mentally competent or cooperative enough, you should not be choosing non-invasive support for them in the home setting. Typically, if you're using non-invasive support, you don't want to have the patient on a ton of oxygen, because that increased oxygen need indicates the patient's not very stable. And if they, for whatever multitude of reasons, the non-invasive comes off, the patient would be in a bad situation fairly quickly. You also want to make sure that the patient has the ability to protect their upper airway, has the ability to, protect their upper airway from obstruction, and be able to protect their upper airway from secretions. Okay, and then finally, they have to be able to wear the interface, so no facial trauma or conditions that is going to make it so that the patient can't wear a non-invasive mask. Okay. So when it comes to selecting the appropriate ventilator, you do have a box on the top of page 1290 that lists like the equipment and supplies needed for vent-dependent patients. So when you're picking out what type of vent you want to use, you're going to make that choice dependent on the patient's needs and the ability for that vent to be backed up if the patient can't maintain that spontaneous ventilation. Okay, so you don't want to send them home with one piece of equipment, and then if something fails or whatever, that the patient wouldn't be able to breathe on their own for about 4 hours. These ventilators need to be kind of dependable workhorses. They need to be easy to operate. They must be portable so the patient can be kind of mobile. Typically, we like electrically powered ventilators in those alternate health care sites. I feel like this is always an MBRC question. Pneumatically powered ventilators require that high pressure oxygen source or gas source. So if your gas source fails, your vent is not going to work. So that's why electrically powered ventilators with battery backup is always the choice to pick when it comes to sending a patient home on a vent. So a lot of patients in the home care setting actually like the pressure control modes over volume cycled modes of ventilation. which is interesting because uh, that, is kind of different than what we're kind of used to a little bit. So those uh yeah. So typically, like, you're going to be setting a pressure and it's going to be cycled off by patient's um flow. Flow demands is what that kind of means. Patients with neuromuscular disorders usually prefer volume ventilation, so it means you're setting the volume. Biggest challenge is going to be getting that good, comfortable, leak-free interface, typically, when it comes to NPPV. Okay. When we're talking about bland aerosol, um, so bland aerosol, again, is that delivery of sterile water, using various concentrations of saline in that aerosol form. So these are either your ultrasonic or jet large volume nebulizers are what's going to be used for this. You could do it intermittent or continuous. May be useful. So you're going to recommend this on patients with thick secretions. As an adjunct to other airway clearance procedures like CPT, stuff like that. And the big risk with these patients is infection. So from contaminated equipment, so you're going to want to make sure you're cleaning your equipment and changing it regularly, which we're going to talk about when that's recommended later on in this chapter. Aerosol drugs. Aerosols is popular for drug administration in respiratory patients. So typically it's going to be those beta-adrenergic bronchodilators, which is your albuterol, your anticholinergic agents, which is your ipratropium bromide or Atrovent, and then your anti-inflammatory agents, which is your ICSs, your inhaled corticosteroids like Pulmicort, clomethazone, things like that. So this is either going to be in that meter dose inhaler, dry powder inhalers, or you can send the patient home with a small volume nebulizer powered by a compressor. Something that you guys might not be aware of, but the decision of what to discharge a patient home on what might come into play is insurance coverage of what their insurance is going to cover better. So I always say it's just like, don't order a patient. If you want to ensure non-compliance, order a patient on something that they can't afford to do once they leave the hospital. So that's the number one way you're going to get a non-compliant patient on your hands is like, I ordered you on something that you can't afford to pay for. So as much as some of these guidelines recommend, like, oh, we want you to take a LABA if you're a COPD or moderate COPD, but if the patient can't afford to pay for the LABA, a good alternative would be sending them home with a nebulizer and telling them that they need to do the nebulizer 4 times a day, if that's cheaper for them. Uh, what else was I going to say about that? Oh, the other thing with meter dose inhalers, just as a reminder, is each meter dose inhaler has a recommended inspiratory flow or an optimal inspiratory flow rate. So double checking, especially if you have patients that are frequent flyers, double checking that they actually can derive the inspiratory flow needed for good deposition of that medication. So some of your dry powder inhalers are big culprits for this. The patients that are taking those are supposed to, usually you're instructing them to take that fast, deep breath in to get that dry powder through those large airway quickly so that they don't deposit in the larger airways and deposit down in those smaller airways where they're going to do the most work. So if the patient can't physically do that and physically suck in at 60 liters per minute, then they probably shouldn't be ordered on an inhaler that's optimal flow would be 60 liters per minute for deposition. So that is something too, as you're doing patient education for discharge, you should be looking at. They make these devices called in-check devices that will check the inspiratory flow on patients, and is a good thing for you guys to consider doing with your patients prior to discharge. So airway clearance, and airway care. Patients that are going to go home with tracheostomies are going to require that daily care. Tube exchanges. That trach care can be provided by any trained caregiver. So typically we're going to teach family members, even the patients themselves, how to do their own trach care. Tube changes. Egan's makes a point to say that it should be only done by a nurse or an RT or physician, but I have known patients who have been trained to change their own trachs at home and family members. So that's a little bit of a questionable recommendation. Um, so we will teach our patients to suction themselves as well in that home care setting. So usually they'll have like a portable suction pump, electric suction pump that they can use in the home. And then patients could also, another airway clearance method is those cough assist devices, such as a mechanical insufflator, exfoliator, which helps by using that alternating positive and negative pressure to simulate a cough and lung expansion. So these devices are usually really effective for patients that are on non-invasive therapy to help with that secretion clearance. Um, so other airway clearance methods are um, doing like huff coughs, that forceful exhalation to try to, if the patient doesn't have a good cough themselves, kind of teach them to do this huff cough maneuver where they're like, instead of going, they go like that, and that helps bring mucus into those main airways to be able to expectorate it easier. Another method is that active cycle breathing, and then autogenic drainage methods are where you're kind of having the patient kind of moving themselves around or whatever so that everything moves into those main airways and can be easierly removed. We also train family members and caregivers on how to do chest PT or put patients on vest therapy at home to help with those retained secretions as well. Okay. All right. So nasal CPAP. So typically, nasal CPAP is used for treatment of sleep apnea. So how do we determine proper CPAP level? That's going to be best method is with that sleep study or polysomnogram, where they're going to titrate different CPAP levels and looking at that AHI score index, your apnea hypopnea index. We want that to be less than 5. So anytime that AHI is above 5, that means you're not on an appropriate CPAP level. They also do remote telemonitoring, where patients can go home and do a home sleep study. That is not usually the recommended method, but a lot of places are switching to that because of CMS and reimbursement. So nasal CPAP is probably the most acceptable form of therapy to treat sleep apnea. So in order for Medicare to reimburse it, you do need to get that polysomnogram for that diagnosis. Sometimes we'll also do apnea monitoring at home for patients that have recurrent apneas or bradycardias or like hypoxemias. So typically apnea monitoring is used for infants. So infants with prematurity are going to go home with apnea monitors when they leave the hospital. We usually, I used to have to do friends and family CPR when I worked in the NICU. So the family members were trained on and we actually did scoring of apnea monitors at St. Joe's Milwaukee NICU. So patients would be sent home with the apnea monitors. We would then download the recordings of these, or they would do like an apnea testing in the hospital. We download the recordings of these and see how many apneas the patient was having. Yeah. So most apnea monitors are going to detect respirations and heart rate. And if they notice a period of apnea for more than usually 20 seconds, it's going to alarm like crazy. It's super loud. And then families can kind of come in and stimulate the baby and get them out of the apnea. So we train the family members on that. We've trained them also on, CPR in case the apnea turns into something more significant. So typically they're going to go home with us for like anywhere from 2 to 4 months, typically. All right. Almost done here. So patient assessment and documentation. We already mentioned that respiratory therapists outside the hospital actually have to document more than those in the hospital. So you are going to need to document a lot of patient assessments, put in a lot of information into the chart for that reimbursement criteria. So one of those things is screening. So on admission in those long-term care facilities, all patients are going to be screened by an RT. This, is usually to get that pertinent respiratory diagnosis, information on symptoms, chest X-ray results, PFT results, ABG results, other things that are not respiratory in nature that might be ordered. If there's something that's uncovered in that screening that needs more evaluation, they would maybe do like a patient interview and an assessment of the patient. So during that screening process, they're gonna use that information, and the RT along with other members of that care team are going to make a specific plan for treatment for that patient. That's going to include things like short-term, long-term goals, overall prognosis or potential for the patient to be able to successfully complete the rehab, and then how we're going to measure those goals. Okay. So this is kind of going to be our therapy plan. So you are going to, after it's initiated, you're going to be doing ongoing assessments, monitoring the patients to, kind of be able to document that patient's progress. So there's a lot of summary documentations, and, assessment of goals and achievement of goals documentation that goes through that stage. And then as they're kind of reach their full potential, this is when we can start looking at discharge summaries for the patient. So if they got discharged to a long-term facility and you're the RT there, and now they're getting discharged home, what you're going to want to put a discharge summary in that describes everything that you've done with the patient and whether you were successful or not in achieving the goals that you'd initially set out for the patient, and anything that the patient would then need to be doing in the home care setting. So for home care, so some factors to consider when determining like home care visits. Really depends on like patient's conditions, their therapeutic needs at the time of discharge into the house, how much support they have from their family and the other caregivers, how technically difficult that home care equipment is. Obviously, like a bland aerosol might not require as much follow-up as somebody that went home on a ventilator. The patient's ability to do things for themselves. So if a patient's really good at their own trach care and really good at their own suctioning and managing their tracheostomy, I might not have to visit them as frequently as somebody who struggles with doing some of those steps. Um, so, kind of the function, why there's a need for respiratory therapists in these home visits is to do that assessment, right? So we are the only medical profession that's, focusing just on that cardiopulmonary assessment. So you guys are about to complete 2 years of education on just cardiopulmonary assessments. So these are, what you've specialized in the last 2 years, and this is kind of the value that you're going to be providing your patients both in the hospital and in the home. The other thing you're going to be evaluating is that patient's compliance with the treatment plan. So we all know how non-compliant patients are at home. So I think the big thing for you guys, if you do go work in the home care setting, is to ask yourself, not only documenting that non-compliance with the treatment plan, but trying to root out causes or barriers to compliance. So there, like I mentioned earlier, financial strain. Typically, our patients aren't just diagnosed with COPD, they also are diagnosed with a number of other disorders that require medication and require maintenance, and that can sometimes be very overwhelming. So sometimes we can be like, you didn't just go fill your $40 albuterol prescription. Come on, go get, you have $40, go get that filled. But what we're not seeing all the time is the fact that it's $40 for albuterol, but $150 for this med, and I still need to put gas in my car, all these other things. So that's why that multidisciplinary approach is so valuable, because sometimes we get a little bit of tunnel vision about what our patient needs, and we're not also being fully aware of all the other things that they're trying to do at the same time that can overwhelm a patient and make them non-compliant and make them struggle with continuing with the treatment plan. So when you identify those things are things that you need to report back to the team, the care team, so that, adjustments can be made. Equipment assessment, you want to make sure that the equipment's in good working order. Identify any other patient problems the patient might be having. They might have a change in their situation, where originally they got discharged from the hospital and they were going to go live with their sister, but then they got in a big fight with their sister, and now they're not living with their sister. They're living somewhere else. So lots of different problems. There's a million different scenarios for other problems the patient could be having. But again, we should be kind of, when we're doing our assessments or when we're with our patients in those home care settings, looking at the big picture and trying to identify things that are going to cause the patient to struggle and may mean that the patient's going to end up back in the hospital. And then finally, you're just going to be, making sure that the goals we've set for the patient are appropriate and that the treatment plan is going to help them achieve those goals. So adjustments might be needed with that. All right. And finally, equipment disinfection and maintenance. So, you're I think we all should know that we're probably the number one reason that people get infected with hospital-acquired infections is healthcare workers with that indirect content, not washing your hands, contaminated equipment. Well, these problems get exponentially worse when the patient gets discharged. So to help minimize home-related infections, there's guidelines that the AARC has put out for disinfecting home respiratory equipment. So these guidelines, focus on the sources of infection, principles of infection control, what patients are most at high risk, different infection methods. So, so step one is always going to be proper hand hygiene. In addition, we want to educate patients and family members about discouraging visits when somebody has a respiratory infection. So especially during cold and flu season, don't come visit my kid that has very severe cystic fibrosis if you've got an upper respiratory infection. um, you want to make sure that you're following manufacturer guidelines for medical equipment for any type of high level disinfection that they might be recommending, or how often things should be disposed of and replaced. So disposable single patient use equipment should only be used for that one patient, should not be cleaned and reused. Um, I'm not sure if everybody realizes this, but there is a difference between the hospital's small volume nebulizers and the ones that the patients get for home care. Those home care nebulizers are rated for long-term use. Usually, I think it's 6 months, and that means that they've undergone testing to show that they generate the appropriate particle size after 6 months of use. The ones that we use in the hospital are actually only rated usually for only a week. So this is why some places, some really good hospitals, have a standard practice that they replace the nebulizers every week in the hospital. Because after that, you may not be able to ensure good particle size. And if you don't have appropriate particle size, you don't get appropriate lung deposition, and you might as well have just wasted 15 minutes of your and your patient's life with that nebulizer treatment that you gave. Um, so, uh, for disinfecting equipment, oh, I should have been. For disinfecting equipment, you want to make sure that it's completely disassembled. You usually wash it first in water, or soak it in warm soapy water for a couple minutes. Anything that has visible like organic material on it, like mucus or secretions, needs to be scrubbed clean, and removed, because remember when we talked about infection control in the survey, if it's not clean, it cannot be disinfected, because any organic matter, you can't sterilize underneath whatever that is. So you want to make sure you're cleaning it off really good first. That's the first step. After you've cleaned it, you're going to rinse it, and then usually air dry it on a surface, um, to minimize recontamination. So usually we tell our patients, take your nebulizer apart, soak it in warm soapy water, make sure everything's clean, leave it out to dry on a paper towel or a washcloth or something, or clean washcloth in the house. You can also recommend disinfection solutions. So typically this is like vinegar water mixture. So like 1 part vinegar to 3 parts water. Soak it for like 20 minutes is typically what most recommendations are. All right. If you have any questions about that, please let me know. Otherwise, please review your chapter 15 in your Pershing's book and complete the outline for extra credit.